From surgery to rehabilitation, robotics is revolutionizing healthcare like never before. To explore how AI and robotics are helping doctors perform with utmost precision, please welcome Dr. Sanjai Addla, Senior Consultant, Uro-Oncologist and Robotic Surgeon at Apollo Hospitals, Hyderabad, for the fireside chat on healing with precision, the new era of robotic-assisted care. You would be interested to know, welcome sir, you would be interested to know that he has 18 years of experience just doing robotic-assisted surgery. Most of it has been in the UK, where he has been working with the latest technology in robotics, performing surgeries, and he has also been training young surgeons in robotic surgery, something that has been discussed in greater detail in the earlier sessions. So while we had a view of a robotic-assisted surgery, you would be interested to know it actually has its roots in defense. So before we begin on how, Dr. Adla, could you take us through that journey on how robots actually came from battlefield to your operating table?
Thank you very much for this opportunity. I just wanted to show that video to identify two aspects to it, in that the surgeon sits on a console and controls the robot. The robot does not have AI. There is no artificial intelligence to it. So this is what you call as a master-slave technology. The surgeon is the master, the robot is the slave. There isn't any artificial neural network, there isn't any artificial intelligence. Yes? Initially, it started off its journey in the early 90s as a US defense project so that they can defuse the bombs. So the surgeon or the bomb diffuser will be sitting in the safety of the control tower and send the robot out to defuse bombs. The issue was that the robot was so heavy that it would keep on toppling off. And even on a flat surface, it needs somebody with a bit of a muscle to push it. Now, almost 30 years after what they have started off. So at that time, it was quite heavy. So they said, okay, there isn't any role for this in defense. So they give it off for civilian utilization. And that's when the journey of the robot that we showed in 1997 started. 3 engineers bought the rights from the US Defense and then kept on developing it. Now it is in the 5th generation. There is the Da Vinci 5, which is the 5th generation robot. DV5 hasn't been introduced everywhere in the world, but DV5 is what we have in Apollo is the 4th generation robot called as the XI. How much of my work? I have been doing this robotic surgery for the last 18 years. We have been doing robotic surgery for the last 25 years. So though it might sound all new and unique, it isn't. I have done more than 1,200 of these procedures. I've done 2 in the morning. So it is more of a day-to-day basis. This is what we do, and this is what we have been doing for the last 25 years. So robotics, whether we like it or not, is the current standard of care. It's not the future.
So, Dr. Adla, a lot of times families are given this choice whether they want to go through the conventional procedure or use robotic-assisted surgery, right? So, what are the benefits it brings to the table? So, like our audience, because a lot of times we all have to make such decisions at some point in our life, right? So what would you like to share?
So there have been 3 generations of surgeries that have happened. The first one was open surgery, which has been done since the time of Sushruta, wherein you made a cut from top to bottom. Your 2 hands and the assistant's 2 hands went in to do the conventional surgery. Then late 80s and definitely early 1990s, when it started off being called as a keyhole surgery, in that you put a telescope in and do the surgery. Mainly gallbladder surgeries were the commonest and hysterectomies were the commonest. But the problem with now we call it as a traditional laparoscopy, is that everything is stick surgery. Everything has to be straight. And as we know, everything in the world, as well as everything in our body, is not a box. It is a round thing. And I'm trying to chisel out a round thing using a straight thing, which is not possible. So that's why the robot has come in, wherein it replicates whatever I can do with my hand and even a bit more. I can rotate it 3 times. It can rotate even more without getting bored. And it replicates it immediately without delay to the same extent as I do. So what tends to happen is I'm doing the traditional laparoscopy, but with a lot more precision. That's one. Second, I operate with 40 times magnification. And that is my standard vision. Even a centimeter one looks like a 5-story building to me. Yes? So any cancer, I'm able to do it better. So what we have shown in the last now 25 years is robotic surgery is much more precise. That's one. Like both those patients, one patient will go home later in the day today, the other patient will go home tomorrow. I operated on them for 4 hours. The reason is I'm not putting any tension. So what happens with traditional laparoscopy is anything that is round, you pull it to make it a straight line. And when you pull any tissue, even if I don't break your hand, if I twist it very hard, you will have pain in the evening. Same thing happens with the organs in the body. So though you haven't cut it, the amount of tension you put during laparoscopy is more. So the recovery is a lot more quicker. The precision is there. And the third, which is more important, is I'm operating sitting down. I can operate for 10 hours, still not feel tired. And the biggest they have done is, like if you have even a mild tremor, it will take it off. So what tends to happen is normally you don't have tremor, but when you're operating on something that is life-threatening and everything is important, all of us are human beings, we can have tremor. It will scale it down. It will take away the tremor so that I'm able to operate with 40 magnification with a 3D vision without any tremor. So that's what makes it more precise, and that's what transforms into better recovery, much quicker recovery. A patient, typical example I give is a patient who was a postman when I was in England. He sought me out from long distance. He came to me and I operated on him on Thursday, discharged on Friday. So he said, when can you go back to work? I said, just take 2 weeks off. I said, sir, I live alone. I don't have much to do. I said, okay, whenever you feel like. So on Monday, he was fine. He went to the post office and said, I know I'm not officially at work, but can I just go and drop off a few letters? He did that. On Tuesday, again, he did it. And then he said, on Wednesday, I just went back to full-time work. So what we are able to do is return an individual back to his normal role in the society. He's no more a patient. And that you can't put a value on. So answering your compared to conventional, the cut is smaller, the precision is higher, and that's what transforms into better cancer cures, much earlier recovery.
So while, I mean, these are fantastic positives that you have given us, better recovery, better outcomes, better precision, better optics for the doctor. But are there any precautions or risks that families, patients should know about?
There are 2 ways of looking at it. There are no precautions, it's straightforward. Any operation, you show it to me. Just because I've been doing it for such a long time, I can replicate it using the robot. Just because for me, extension of my arm is the robot. And with a lot more precision. Like when we started off, just to make people, I can peel an orange with a lot more precision without crushing anything. I can make a coffee with it without spilling anything. And these are the mundane things, but just to say that it is me. It's not a robot, it's robo-assisted surgery that's being done by me. So are there any precautions? The surgeon who is doing it should be well enough trained. Those things is the only precaution. Otherwise, it is as safe as whatever the traditional surgery is.
And are there any procedures where, like you showed us a surgery that was urology and oncology related, right? But are there specific procedures where robotic surgeries usually are recommended a lot more?
So actually, when the initial robo was designed, it was designed for cardiothoracic surgery. The reason why cardiothoracic surgery is, all of us have family members. If they have had a bypass surgery, they would have the chest opened up and do the surgery. It is a morbid procedure just because we are undoing what God has done for you. He has protected your heart and we are unprotecting it. Yes?
You mean in the rib cage? Everything
You have to open up the rib cage to do the operation. So they thought, okay, robotic surgery we would be very good. We don't need to do the sternotomy. But the risk with robotic surgery was so very high. Any complication in cardiothoracic is death. It is not a bit of infection or anything, it's death. So the risk was so high, the one that stuck was the urology procedure. The reason why urology procedure stuck is prostate is deep in the pelvis. deep in the lowermost part of your body, the prostate is. And that's the reason you need the precision, the access to do things, as well as the endo-wrist movement. Prior to doing the robotic surgery, I would have, let's say, 3 prostates. I would always say, I will try doing it. The reason why I would say I would try doing it is, if the anatomy allows, if the amount of fat is less, if your body habitus is fine, I will try doing it. Whereas now with the robot, it has normalized, it has democratized the anatomy, it has democratized the quality so that even normal surgeon look very good with the robot.
Wow, okay, very interesting. So that's a lot of positives that they bring on the table. Also, but how far are we, or will there be a time where, like currently, like you mentioned about how it is, the AI is not there. It is doctor assisted completely, or the doctor overtakes it. But will there be a time when a robot will be able to do it independently, or at least some easier procedures?
There are 2 ways of answering the question. All of us, or majority of us, have iPhones. iPhone uses a lot of AI. If anybody has a Samsung phone, when you start taking a picture, it will identify the face and it will identify whether the person is smiling or not. That is AI. It is not shouting at you to tell you that it's AI, but that's what it is using. The moment somebody calls, it will recognize, oh, you have met this person. Even you might forget, but the phones remember. Yes. So the best AI is wherein it doesn't tell you it is AI. It is already there in the background. So does the new robo have a lot of AI? Yes, it has a lot of AI. Making my job easier to do the operation. Yes, it doesn't independently do it. Recently, all of us, or some of us, would have read in the news that robo has independently done a gallbladder surgery in a pig. So there were 8 steps. They kept on taking it through, and it did the independent surgery. So they said, okay, this is the AI.
Not on a human.
Not on humans. Yes. So they said, okay, robo can do an independent surgery independent of a surgeon. So then there was a press conference after that. So they said, okay, now this technology is available. How many of you are willing to have a robo done surgery, not robo-assisted surgery? Nobody lifted their hand. The reason is still there is that fear of machine, whether that is the Terminator that has done to us, there is that fear of the machine. And the second element of it is, there has to be a human touch. There is a variability with respect to what we are. If our fingerprints are so different, our inside is a lot more different. Everybody has a unique anatomy. Everybody has, yes, the robo can learn and it can help me do it. So will AI come and take over my job? No is the straightforward answer, but will it make my job easier? Definitely yes.
But a lot of times robotic surgeries do come with a very high cost, right? How much is the price differential, if you may share?
You can't put a cost on it. I'll tell you the reason why I'm saying. So I was in UK for 20 years, so I had to make a business case for a robo. Robo was £2 million at that time. So you can say around 20 crores. Yes. So I had to go to the primary care trust. And I said, she was a lady who was in charge. And I said, okay, you are in your 50. Your husband probably is 55 to 60. I will do a radical prostatectomy in the traditional way. He will go home on day 3. There is a 1 in 4 chance that he might need blood transfusion. And he will become continent, i.e. he won't leak urine by 3 months. Okay. Or you want me to do a robotic surgery wherein I've transfused 2 patients in 500 cases. He will go home on day 1 and he will be continent, i.e. does not leak urine by 2 weeks. The cost difference is 2 lakhs, 2,000 pounds. Do you think the social dignity of your husband for those 3 months is worth those 2 lakhs? She said, that's a no-brainer. Of course it is. So the biggest difference that we are talking of is, I'm not talking of people who are retired. These are active people who are the center of the families. The earlier I return back them to the society, not as a patient, as an individual who is able to deliver what his responsibility is, as a father, as a mother, as a whatever their roles are. So you can't put an actual value, but giving a number, it's around 2 lakh rupees.
Okay, that's not much, but for a country like India, where, I mean, a lot of areas are underserved. There is a huge urban-rural divide. How can we bring robotic-assisted surgeries to the people at the bottom of the pyramid, or can we?
So I'll answer the first question and then the second part of the first question. So if you think robo surgery is unique, there are 15 robos in Hyderabad. Yes? So it isn't something that is...
1-5.
1-5, yes. In India, there are probably close to 250, yes, of different makes. There are that many are there. So whenever I'm doing, the reason why I showed that video is there is the console where the surgeon operates, and then there is the machine that actually the robo, that patient. The division, the distance between them can be any distance you want. So what they have done is, even in 2003, they did a transatlantic surgery. So the surgeon was in London, the patient was in New York. Recently, it was there all over the news. There was surgery done by the surgeon in Hyderabad, patient was in Delhi.
Yes.
There was a major colorectal surgery lasting about 3 hours, done with the surgeon being in Chennai, and the patient was in Delhi. The reason why these things are important is they're absolutely important for India, so that I keep on using the word democratization of quality. If you look at I'm a urologist. If you look at urologists, overall there are about 600 urologists for whole of AP and Telangana, out of which 350 are in Hyderabad.
So there is a very strong
Huge concentration of specialists in centers. If, let's say that there is somebody in Srikakulam who says, okay, we are going to establish a regional cancer center, you don't need to travel there, but initially train up the team that is there and be available in case if we are in trouble, or if it's a new case, just operate from Hyderabad. Yes? And these are not fictional. This is real.
And this is the present.
Done.
It's not the future that we're talking about.
So this is done. So if robos or remote surgery had a role anywhere in the world, it is in India. Because there is such a huge variability with respect to the quality of the expertise. Again, democratizing means I have to be available everywhere, wherever there is a need. Not patients traveling. It takes 3 days for a patient from Guwahati to come down to Hyderabad. Why should they be doing that? They have a robo in Guwahati. I should be able to mentor from here. Initially start doing the operation, mentor, and then troubleshoot. So yes, it is expensive, but it is well worth the investment for India.
You mentioned about mentoring, right? And the earlier session also spoke about the very critical part is to now train, the new workforce that is coming into these new technologies. So all our new surgeons who are coming, how easy or difficult it is to train them? And is our curriculum, medical curriculum, is it up to date with these technologies?
This is, as I said, this is the current standard of care. That's how it has to be. If you take the example of, does MNJ Cancer Center have a robo? Yes. Does NIMS have a robo? Yes. So all our major centers do already have a robo. They already are doing it. And of course, all the trainees who are coming out of there will be trained. So it is a problem that is easier to deal with rather than we think. That's one. And second, I'm 52. I'm probably one of the last surgeons who did open surgery, laparoscopic surgery, and robotic surgery. So when laparoscopic surgery came in, they said, oh God, what happens in case if they have a complication and they have to cut it open and do it? I haven't done in the last 1,200 cases. So if I never needed to convert a robotic case to an open, why should I even have the training in doing an open surgery? Because it is such a rare occurrence. If it does happen, we have to deal with it. Like you can't have your airbag on in the car just because I might be involved in an accident. Yes? You will deal with it when it happens. So in the same way with this, the curriculum is updated. Majority, all our aims have the robo. So it is not a technology that is, as I said, it's not a new thing. The innovations that are happening in it are newer. Okay. In that you will have what we call as a tactile feedback. What I mean by tactile feedback is even if I close my eyes and touch this, I know this is slightly hard, this is slightly soft. Even if I didn't have it, even if I use my pen, I still know it. But when laparoscopy came in, they said, oh, you don't have the tactile feedback. But mine developed and said, actually I can feel that this is hard, this is soft. Now with the new robots, actually tells me that is soft tissue, don't pull on it. And the second one is, there are certain things called as the no-fly zones. No-fly zones is when you start the operation, you find the arteries and put them in red color and say, don't allow me to go there. It doesn't allow. So if, let's say that I'm leaving the trainee to do the operation, I just put the no-fly zone here, and then I go and have a coffee or see another patient and come back. And it would not allow him to do any dangerous mistakes. And again, this is not future.
This is now very interesting. So, Doctor, what are the 4 or 5 big takeaways that, I mean, we have spoken a lot about the positives, what it brings to the table, but what are the 4 or 5 takeaways that you would like to share? Because, I mean, the way the incidence of cancer is increasing in our country, the types of cancer has changed drastically over the last few years. So if you can talk to us about that, on what we should know.
So I'm a cancer surgeon, so I would always say that there is a problem, but 2018 was the watershed year in the health economics of India, 2018. The reason was, 2018 was the year when breast cancer overtook oral and cervical cancer as the commonest cancer. I just want to highlight this. Only women have breasts, but the commonest cancer in India is still breast cancer. Just because the incidence of breast cancer is so high in women that both male and female combined, breast cancer is that very common. The second point to note out of that is cervical cancer is an infection-related cancer. Oral cancer is a habit or an infection-related cancer. Breast cancer is a lifestyle-related cancer. So past 2018, whether we are a developed country or not, we are getting the diseases of developed country. We might as well be aware of it, get ourselves screened. The incidence of screening in India, even in government-sponsored oral, breast and cervical cancer, the coverage is 1%. The only way we can cure the cancer is by picking it up before anybody has any symptoms. So if there was one message, one is cancer incidence is on the rise. That's one. Second, the only way to prevent death from cancer is screening. The earlier we pick up, the cheaper it is, the more effective it is. And we have got every technology that is available anywhere in the world in India to cure you. But whether we are curing or not is dependent on you. And then the third element is, again, the cardiac issues that we are seeing. Those are the diseases of the developed country. We are already seeing that. So cancer is on the rise, breast cancer especially is on the rise. So please do get yourself screened. The best chance of cure is before you are symptomatic.
So thanks a lot, Dr. Adla. And one very big takeaway, at least for me, is lifestyle cancer is on the rise and screening is the only solution. So thanks a lot for this wonderful conversation.